Okay, thank you very much indeed. Good morning, everybody, and a bit late, but happy to be here.
Speak a little bit. My hearing aid's gone.
Your hearing aid's gone. Can you hear me now when I speak through the microphone? Hope so. Right. As we just heard somebody's computer, can you turn your volumes down or off, or your phones off, please? Right. Before we start, I need to inform you that this meeting has been live streamed and recorded. Please also note that all remote participants are muted at the outset of the meeting and are only able to speak at the invitation of the chair. Please raise your virtual hand if you wish to speak and then only unmute when the chair invites you to make your contribution. As chair, I may ask that you are muted if you do not participate in this way. So those are our rules for today to ensure that the meeting runs smoothly, which I'm sure it will. Item 1 on the agenda, apologies for absence. We have Jeff Anderson. Any more? Yes. Item 2, disposable interest. Has anybody got any disposable interest in this meeting? If so, please let us know.
Excuse me, sorry, it's my usual that I'm working the GP practice in Ludlow, just in case.
Thank you very much indeed. There and that. Item 3, minutes of the meeting held on the 20th of November 2023, which I can see is 5 minutes ago. Are we all happy with those minutes? Have you all read them and you're happy? Pros from Ed. Everybody happy? Good, thank you. Big accepted. Item 4, public question time. There are no questions from the public, so we can move on. Item 5, member question time. There are 3 questions. Oh, sorry. Bernie, Heather Kidd and Roger Evans. Bernie, would you like to read your question?
Thank you, Mr. Chairman. My question is regarding Shropshire's emergency services. A report to the South Trust Board on 14th of December 2023 revealed 140 deaths in the emergency department between October and December 2022, double the number for the same period during 2021 and 3 times the national average. Hospital discharge delays have dropped to an average of 115 per day for the first week of January 2024, compared with 150 to 160 for most of 2023, which is very welcome. Accordingly, admission delays should reduce. But the mean time for admission to an inpatient bed in November 2023 in the Shrewsbury and Telford Hospital NHS Trust was 21 hours. SATH was one of 5 trusts called to a meeting with the Health Secretary Victoria Atkins on the 18th of December 2023 over the 2,550 Shropshire ambulance lost hours in the 3 weeks to the 10th of December 2023, one of England's worst performances. So my question is, how many emergency department deaths were there in 2023? And that was the whole of 2023. And what steps have been taken to deal with this appalling loss of lives? How many deaths were reported to Shropshire's coroner over the last 3 years? And how many and what was the content of any Regulation 28 notices served on the Shrewsbury and Telford Hospital? What urgent steps have been taken to reduce these delays when a national study suggested that there was increased mortality in patients waiting more than 5 hours in crowded conditions in the emergency department for a bed? And what was the outcome of the meeting with the Health Secretary? And that publication was in the British Medical Journal. Thank you.
Question.
So this is the response to the committee from the Shrewsbury and Telford Hospital NHS Trust. In 2022-23, there were 404 deaths in ED departments, of which 163 were referred to the coroner. Over the last 3 years, there have been 361 ED deaths that have been referred to the coroner, 101 in 21-22, 163 in 22-23, and 97 in 23-24, 4-1-3. In respect to the Regulation 28 notices, SAF has received one within the last 3 years, in May 2021, and it was not related to a death in ED. SAF carried out a review of the increased deaths noted in Q3 of 22-23 in emergency department. The review did not identify any overall failures or omissions in medical or nursing care that were considered to have adversely impacted on the outcome for patients. Although a greater proportion of admitted time in hospital is now within the ED footprint due to the system pressures in UEC, this can only partly explain the rise. The report concluded, in line with published evidence, that the increased deaths within ED were likely to have been in part related to the increased length of stay within ED. This was likely to have had the greatest impact on older, frailer patients. The increase in deaths was representative of the national picture, albeit the increase was greater. It is difficult to separate the effects of other delays occurring elsewhere in the system that are likely to coincide with times of excessive waits in ED, and the review did not include patients who entered the hospital in a peri-arrest state or had sustained an out-of-hospital cardiac arrest. System-wide improvement working is ongoing, including but not limited to: 1. Opening of 2 rehabilitation and recovery units, 1 in each hospital site, in January 2024 to provide additional capacity. 2. System-wide ambulance delay escalation process to ensure additional actions in time of sustained pressure. 3. Hospital full protocol to increase capacity and relieve pressure within ED to alleviate overcrowding. 4. Targeted work to improve time to initial assessment within ED. 5. Proactive work with the local authority colleagues to flag patients who may require support prior to them becoming medically fit. 6. Frailty model being reviewed and developed to ensure patients do not spend significant periods in ED and have appropriate assessment, support and care if required.
Can I ask a supplementary, Mr.
Thank
Chair?
you. Wish you can.
Thank you. My supplementary questions are 2. The first is, have the 2 rehabilitation and recovery units actually opened, and are they fully functional? And the second is, what were the deaths in 2023 in the emergency department, not just the time leading up to the end of year 2022-23, which of course was at the end of March. Thank you.
Yeah, thank you. Good morning, I'm Gareth Robinson. I'm a NHS Shropshire, Telford and Wrekin Director of Delivery and Transformation, and have the urgent emergency care work within my portfolio. I'm sure familiar to many of you from previous settings. Thanks, Bentic. In terms of the initial question around the rehabilitation units, they are now both open and fully functional. So the first one came on stream on the 2nd of January, opening 20 beds at Princess Royal Hospital in Telford, and the second came on stream. It was due to be the 15th of January. Oh, forgive me, sorry. Is it the left button?
Yeah.
Is that better? Can you hear me now?
Right, that's the right.
There we go. Forgive me, apologies. So I'll just roll back 30 seconds. So the first ward was open at Princess Royal Hospital in Telford on the 2nd of January, giving 20 additional beds into the system. The second set of 20 beds were due to open on January the 15th, and they were pulled forward by approximately a week. I think it was January the 7th we actually ended up opening them, but I'll confirm the actual date. So that gives us 40 additional beds into the system. We have a further 6 scheduled to open on the 5th of January. These are currently delayed with a small amount of estates work that is required at the Shrewsbury site. That will give us 46 additional what we call subacute beds. So these are patients that are completing their most intense acute part of the pathway and would ordinarily be cared for within a community hospital setting. And it's an excellent way of providing the correct pathway through for patients through back to where they are best cared for in their original place of residence. In addition to that, over the Christmas period, which is well known for being the busiest period of demand, we were able to open 16 escalation beds of a similar type at Robert Jones Agnes and step forward and take us through one of the highest risk areas. They opened on the 26th of December and then closed again on the 7th of January, which gave us a real step change in capacity through one of the most challenging periods. On top of that, there's a raft of additional work around the expansion of virtual wards, around the role of rapid response units, and the increased capacity that we're seeing within complex discharges through the social care packages. So I'm really comfortable that the capacity that's coming from this area has been a real boon to the system. In terms of the second question, what were the deaths in 2023 in ED? Unfortunately, I appreciate my encyclopedic knowledge only knows certain bounds, so I can follow that up and come back separately.
Thank you, but I did ask for the 2023 figures, the original.
I apologies, I only picked up the response on Friday, so I will check that.
Thank you.
Good. Thank you very much indeed. The second question we have is from Councillor Heather Kidd. Heather.
Thank you. And I say, I'm sure you're looking.
Heather, can you put your microphone on?
Sorry.
Well, please. Thank you.
Sure, you'll be delighted when they open the new beds in Bishop's Castle, since we're nearly fully staffed there. Sorry. My question. South has received 21 million to help with winter pressures, which is a good deal. And industrial action has mostly affected the number of elective procedures and routine clinic appointments and investigations. How then has the anticipated deficit, and I apologise for the extra noughts in my question, so quickly risen from 57 million to 130 million by the end of the current financial year, representing 14% of its budget? And what measures will be taken to deal with that?
Thank you. Gareth, please.
There is a response from SAF in terms of the SAF aspects there, and SAF very kindly produced a response, but the numbers that you required were conflating two areas. So the £21 million has gone to SAF in terms of the winter pressures, and that's been allocated to the wards which have opened. The 57 million to 130 million, or 130 million, I'd not got that either, is eye-watering in the smallest number, never mind the biggest. But that is the system position, and actually what the SAF response describes there is the cost pressure that allocated SAF. On top of that, there are two significant cost pressures that are contributing to the 130 million predicted position. One is, well, it's three. There's the first is the drift in medicines management spend and pharmacy costs. So both the utilisation and the unit cost of medicines management has significantly increased the cost within the system and all providers, as well as the ICB. I can't remember what the actual number is off the top of my head in terms of that breakdown, but it's a multi-million pound number, and that's consistent with all health systems and contributing heavily to the NHS pressures across the board. Similarly with individual commissioning, so these are the really complex packages of care that we provide. That overall spend is upwards of £90 million per year, and that has had a significant increase this year as well in terms of utilisation, so the number of patients accessing it and the cost of packages. Some of that has been mitigated by good commissioning arrangements jointly provided between Shropshire Council and NHS STW, but again that's a position that is felt across the board. We have a really intense programme focusing on the costs that are attached to that to try and drive those down as much as we can, but in many ways we're in the same position as other systems nationally. And then the final part of it is the generic inflation costs. That is having a material impact. Our assumptions at the start of the year were set through an HSE guidance where the inflation cost assumptions were significantly lower than they played out across the board. When you add those three things to the aspects that SAF have described in terms of the workforce and the agency costs, that's the build up to 130 million at a headline level.
So will we as a scrutiny committee see how you've tried to drive down those costs in the future? Because, and I know it's going to be difficult because inflation is much more than the 4 point whatever it is they think it is at the present time. Within workforces and so on, it's much higher than that. But actually it'd be interesting for us to have that feedback to see actually how we're trying to manage those figures. And we'd already got a historic deficit. So yeah.
Yeah, I mean, I guess we're at the behest of the work programme. I think we'd be really comfortable bringing the financial plan for the year and the decisions that have been taken and the drivers behind that cost and what else we've been trying to do to mitigate that. Equally, we'll be completing the financial planning round over the course of January, February, March for 2024 and 25. And I think once that's locked in, that would be an appropriate thing to come and share with the committee.
Good, thank you. Thank you very much indeed. Third update. The third question is from Councillor Roger Evans, who's not here, so Sophie is going to read this question out on behalf of Roger. Thank you.
How has Shropshire, Telford and Wrekin ICS implemented the NHS Emeritus Scheme announced by Amanda Pritchard, NHSE Chief Executive in June 2023, and which has brought doctors back into clinical practice?
Answer that.
Again, there's a short answer on there. We're part of the scheme, but we've had limited success with it.
I'm sorry, I can't hear them.
Forgive me, sorry. So we're part of the scheme, but we've had close. Technology is amazing if only you use it properly. So there is a short response in the answers. We are part of the scheme, but as yet we've not had any success with that.
Mr. Chair, Councillor Evans has authorised me to ask a supplementary, and that is, given that I personally spoke with the medical director of the Shrewsbury and Telford Hospital about this scheme shortly after it was announced in June 2023, I and no other medical practitioner within Shropshire that I know has received any direct communication about this scheme. Could you advise what advertisements have taken place and what's been done to actually promote clinicians to come back into medical practice and to reduce the number that are in planning to retire because of work pressures and other issues?
So Councillor Bentinck, you're aware, I think you raised this last time we met, and I've certainly fed that back in. I hadn't chased up in terms of your own individual contact, but we'll do that again. I will need to check with Dr. Jones as to what the details are surrounding that advertising approach. I don't have that information to hand.
Thank you. It's not just SAP, is it? It's primary care.
Primary care across the board, and we have 4 providers, so I'll check that with that. But we have gone through a process with a change of chief people officers, which may have contributed to this change.
Clearly, what I'm asking is for you to now engage with local doctors and with the various providers to make sure that clinicians are aware.
Yeah, what I'll do is I'll ask Nicholas White, who's our chief medical officer, to also sponsor that.
Thank you.
Thank you. Can that engagement process be prioritised? Because it is important. I think you've got people willing to help, and they're not receiving any information. That would be great. Thank you very much indeed. Thank you. Good. That brings an end members' question time. Item 6 on the agenda is the Primary Care Access Recovery Programme. And once again, we welcome Gareth Robinson, the Director of Delivery and Transformation, NHS Shropshire, Telford and Wrekin, which is a very long title. Gareth, the floor is yours.
Thank you. Long job title and long organisation name, so take an awful lot of time up on here. I'm really conscious, and thank you for the opportunity to work through this programme. I'm very conscious that I've had the opportunity through, I think, 2 development sessions to brief a number of colleagues that are sat at the table. So I think we're going to have that difficult situation where a number have had a full briefing on it, a couple of times actually, and some are relatively fresh to it. So if I go too quickly or too slow, do please ask me to change pace. What I will do though is I will assume that the document has been read, because it's a document that's been in the community now for some time. I will just walk through the headlines because I think it would be helpful for me to set out a number of the key points that may then drive further debate. But then I think the best use of the time is to open up to the areas of interest for council, if that's okay, Chair.
Fine.
Thanks. So the Primary Care Access Recovery Programme set out within the document has been driven by a number of reviews, not least the Fuller report and Fuller review, which is focused on modernising general practice and really taking advantage of modern ways providing care, both in terms of the clinical practice and the use of technology. And every system has been asked to develop the primary care access and recovery programme in detail, in depth, with some clear measures attached to 4 what we're calling pillars of improvement work within primary care. And those are set out within the document. It sets out, although I haven't counted them, I think there's about 50 pages worth of content in the document, but it's really trying to achieve 3 things. And that's responding to what our patients and citizens are most interested in. The first is improving access to general practice. I think, broadly speaking, and there will always be exceptions, that once patients get in front of their clinicians, our patients and citizens are entirely comfortable with the level of care that they're provided. But there's no doubt that it's access to primary care, and actually all healthcare at the moment, that's the real challenge. We're looking to maintain and improve patient satisfaction. So while we recognise that the vast majority, as I've said, once in front of a clinician, they're comfortable with it, there is always more that we can do. And we're also looking to work to streamline care and advice. And in a world where we do have finite resources, we need to make sure that the capacity that we have available to us is used in the most effective way. So the people that need it most are accessing it, and that they're accessing it in a way that allows us to use our finite resource as effectively and efficiently as possible. And there's always going to be a challenge in that, because our patients will always want the best, most accessible care, when in a world of finite resources, we need to prioritise and make sure they're receiving the right amount of care. And sometimes that can be a difficult thing to balance. If I take you through to slide, not jumping through, because we can go back to any one of the next sets of slides, talk through some of the history of performance within Shropshire, and it compares it to Telford and Lincoln as well, because this is a system-wide programme of work. But we've covered some of the primary care metrics elsewhere, and I want to focus on what's coming next. If I can take you to slide 34 in your pack, this effectively summarises 50 pages into one. The bottom left-hand corner, it talks about the 3 things that we're trying to do through this. As I've said, it's around improving access. Specifically, it's around tackling the 8 a.m. rush. Now, interestingly, while I was sat outside and Sophie very kindly dragging me into the committee, I was actually trying to contend with Riverside Medical Practices access arrangements and organise a GP appointment, which I've been struggling to get through over the weekend because their portal is down, deliberately closed, and therefore I was part of that Monday morning 8 o'clock rush. We're all really familiar with it. I'm dealing with it myself. We're trying to resolve that issue so we don't wait over the weekend. I've been tap all weekend, and suddenly 9 o'clock on a Monday morning I can get in. We're trying to resolve that so patients don't have that anxiety of waiting. Practices don't have that issue of dealing with a massive head of work on a Monday morning, and ultimately we smooth out the access arrangement. Related to that, we're looking to make it easier and quicker for patients to get the help they need using multiple portals. So, for example, really pleased to say, I don't know if some of you were noticing, tapping away on my phone rather rudely while we were working through one of the questions, but that was because I was actually getting my update from the GP through the portal. So I was resolving my healthcare needs entirely independent of needing to tackle a practice. And it's those kinds of avenues that we're looking to resolve. And apologies, Councillor Bentic, while I was doing that, but you will know when you get a chance to speak to your GP practice, it's probably right to take full advantage. And the third aspect is around providing continuity of care. There are 4, as I've described, 4 pillars of work that we're going to be using to try and deliver those 3 aims. The first is around empowering patients, and these are detailed further in the pack. Empowering patients, taking on to about slide 36 now, is around getting the best of the rollout of the NHS app. Just giving you a live example of that, worked phenomenally well for me, but I appreciate others may find it a different experience than that. Increasing self-referral, so patients are navigating around and not having the GP access point as a potential block to accessing the appropriate care, and increasing the use of community pharmacy, which in fact has come on stream over the course of this week to a big step forward. The second pillar is around implementing modern general practice. And this is really focusing on improving digital telephony. So by April this year, all of our 51 practices across the system, and I forget off the top of my head how many of that related to Shropshire, but I should know, all will have a digital cloud-based telephony system, which allows us to better deal with the backlog of calls going through. I'll come back to why that doesn't solve it in a second. but it's also around using online access and trying to stream patients that are comfortable using different access routes into a different place to allow the core capacity within GP to be used more effectively. I'll just focus on that area for a second, because what I don't want colleagues to hear is that by implementing a digital solution from the 1st of April, although we're most of the way there now, that suddenly that backlog issue will be resolved. There are two parts to the problem. The first is how you have the technology to be able to allow patients to access the practice through different routes. If I think through my last visit to Ellesmere in the north, there was still very much focused on a group of individuals sat in a room about the size of the end of this meeting room, literally answering the phone every time. And if you couldn't get through, you couldn't get through. With the advent of the cloud-based digital systems, there will be a much better way for managing those calls, call screening.
Thank goodness.
Yeah. Oh, is that what yours? Okay. And being able to do callback systems, call queuing, navigation to different services using the kind of the numbers-based system. So a better technology solution that won't solve the fundamental capacity issue within our clinicians, but it will help to hopefully smooth out demand, reduce demand, or allow the practices to manage demand when they have capacity available. But we will still have to deal with the core clinical capacity issue. The third part and the third pillar is building capacity in workforce and estates. That's a real challenge. So we've been sat in this room on a number of occasions, haven't we, around the I don't know, Edith, the Cavell Hub. Remember Christine name, but I say that. You'd think that was burned on the inside of my eyelids, wouldn't you? But the Cavell Hub that set out really clearly some of the estates challenges that we have. As a result of some of the work there, we now have an estate strategy which will come forward over the coming weeks. But our focus is very much on developing workforce within primary care, because with all the estate in the world, can't use it if you don't have the workforce. We successfully, over the last 2 years, brought in 200 additional roles over the course of each year into primary care, which is not necessarily GP roles, but are roles that can provide crucial primary care capacity and allow the GPs to be focusing on those patients and that care that is most appropriate. And then the final pillar is cutting bureaucracy. There's an assessment that something like 24% of GP time is spent on non-value add. Value add is a terrible term, but it's not providing care in the way that they want to. What we're trying to do through a number of pieces of work, not least building the interface between primary care, GPs, and secondary care, all our hospitals, is take away the administrative burden that has been set up over the course of years through two things. One is the litigious nature of our society now, where the evidence base is so much more robustly needed to provide security for our workforce. That won't change. But the history of primary care commissioning, GP fund holding, the role of CCGs previously had placed a huge administrative burden on our GPs that we're now trying to unpick and take away so that our GPs can focus on providing care. The document then goes into the really dull but important stuff around governance. What are we going to deliver? Who's responsible for it? When's it going to be delivered? And how do we know that it's being delivered? And the document sets out the governance structure that we'll have in place that will feed into the current infrastructure within the system. So a primary care access and recovery board will be set up. It will be led by Nick White, our Chief Medical Officer. We are asking for each of the groups within the system, so the Urgent and Emergency Care Board, the Elective Care Board, and the Primary Care Board to be led by Chief Execs. So we've got Louise Barnett for the Urgent Emergency Care, Stacey Keegan, the Chief Exec at Robert Jones Agnes Hunt for the Plan Care Board. Fortunately, we can't have Simon on the Primary Care Access Recovery Board, because he'll be marking his own homework when it comes to board. So we've asked Nick White as Chief Medical Officer to chair that board and oversee all of the implementation. And the document goes on to describe how that will be monitored through a series of work programmes and how we'll know that it's been successful. With all of that, I'm conscious you've listened to me drone on for some amount of time. I think there's probably a good point to draw breath and invite questions on any of the areas that are contained within the report that you'd like to dig into.
Thank you. Bradley.
Thank you, Chair. And it's certainly very welcome to see investment in primary care and in reducing the waiting times to see GPs and other professionals in primary care. The documents that you quoted reported only 21 of 51 Shropshire practices being involved in this process. And so what is being done to bring the others on board, and how many of the others are on board since the document was first produced? The second issue, this was brought up in discussions about the document, is what the plans are, both strategic and operational, to reach and engage those people who do not have information technology, knowledge, equipment or experience. And this, of course, encompasses a great proportion of the very elderly, those in their 80s and 90s, who would have very little way of contacting the health services other than the ways they've been used to, that is, going directly to the practice or by telephone.
Thank you, Councillor Bentinck. So, firstly, slightly discombobulated, which happens quite regularly, but I don't recognise the 21 out of 51. So,
it's on this document.
If you could direct me towards that, because I'll need to correct it. All 51 practices are engaged through this process. The mechanism through which we're doing that is through the 8 primary care networks, and each of the primary care networks has an individual and specific plan that reflects all of their individual practices. So you can be 100% assured that all practices are included within that. If there's a comment to the contrary within the report, I'll need to whip it out early. So if you could let me know, I'd be incredibly grateful. Maybe afterwards, if that would help. And then in terms of the reaching and engaging with those that are less familiar with the IT and digital responses, 100%. That is a really, really important part of this. And there's 2 parts to that. One is making those access routes that patients are comfortable with as easy to use as possible. So the digital telephony will allow the use of the telephone, which a lot of our patients do prefer, to be more likely to be successful. So for those patients that want to engage in that way, there will be better access through that route. I think more fundamentally, it is allowing the release of capacity by those patients that are more comfortable through the use of IT and digital solutions to use those and not take up vital time. So this morning, entirely coincidental, I hadn't planned it that way, is the perfect example. Historically, what I was trying to do with my GP would have taken me a GP appointment. Would have taken me to go out, lose a couple of hours of my working day, go and see Dr. Riera in Riverside Medical Practice. Instead, through one online submission and one email back from Dr. Riera, I've released that GP appointment. Now that GP can deploy that capacity to other patients that will be better suited. And frankly, I much prefer that. I think I'd much rather be in hospital with my GP, but I need to carefully think about that. But it really suits me to work in that way. And there is now an appointment for probably Wednesday afternoon that my mum could use if she so choose. It's a really good example of where the use of IT will release capacity to those patients who can access it in a different way.
Do you find the younger ones use this e-consult?
Yes, 100%. That's exactly what I've used this morning. And we now have 3 out of every 10 appointments are done through virtual consultation. So my practice, and again, it's only one practice, but most use the same process, will have gone through the e-consult route, will have then been determined what's the best avenue. And this is, again, forgive me for oversharing, this is a historical issue that I took a phone conversation with Dr. Riera just before Christmas on. So I've got an entire pathway of care that's being provided through one 5-minute phone conversation and multiple uses of IT that would probably have taken up about an hour's worth of her time, which is now released in. Now you multiply that up by, I suspect, I don't know this, but 20 or 30% of the patients that act, or the patient time into primary care practice are probably people like me, or as a dad, my kids. The releasing of that to the patients that want to use different routes that are really important to them, the face-to-face, the home visit, the phone contact is a really vital part of this.
I find they're quite frightened of using digital things on their phone because they don't know where it's going to. You know, that's what I hear when I'm doing a surgery, because that's where elderly people come to me, because they don't want to phone you and they don't want to harass you, but they'll come and talk to you face to face. And them are the people that I worry about, that if you start saying we're going to do all this digital, they'll start thinking I can't do it, and then they're going to be more poorly, where we could have perhaps solved the problem sooner.
Absolutely. So there's two parts to that. The first is the situation I've described. The other bit is actually my mum. My mum is now 70. She won't thank me, so my mum is a certain age. We do find that there's significant evidence of patients in that age group that are probably more, I wouldn't
This one.
yeah, I'm just going to move on. But patients within that demographic can often be more comfortable using the technology than people within my demographic. But we've got to make sure it's accessible to everybody in the way that they are most likely to use it. And we've had useful feedback through some of the developmental sessions about making sure that we push this through the appropriate challenge inequality processes as well. Because it's the ones that don't shout that we need to make sure we listen to.
Good, thank you. So
Just a final one.
and then we move on.
Accepting that there should be additional time released for face-to-face consultations, there doesn't seem to be any evidence of how that will be used in individual practices. You said that it's up to individual practices to ensure that this takes place, but how, as an integrated care system, and us as a scrutiny committee, can we be sure that that time is invested in patients who want face-to-face contact and to engage with their practice in the traditional ways? Because policies are all well and good, but the implementation and the actual practice is just as important.
Yeah, you're absolutely right. You hit on the fundamental issue with the primary care in many ways, which is the nature of the individual practices. So what we're trying to do with this is two things. The first is support our practices with the investment in the digital services to encourage and enable them to deploy these. So there's the supportive approach, but then there's some hard metrics that are included within this. And with the deployment of this process, we'll have 13 metrics around access and engagement and utilisation that go into our quality and performance report that our ICB will have oversight of at a PCN level and GP level where necessary, so we can be really clear about the capacity that's been released, how it's being used. Now, we won't always have the authority or the ability to create a direct link between this has released 15% of additional capacity and have we therefore had 15% more appointments. That link is not linear, but we'll have the availability of the information to be able to challenge our primary care networks and GPs to do this. But I'd almost suggest that they wouldn't want to. Our general practices, we have 51 really, really good practices within our county, and they're all in exactly the same place about trying to maximise the amount of patient care they can provide. So we're with a group of willing participants on this one.
Thank you.
Thank you for that. My only concern is how you're going to monitor it. How you're going to monitor any improvements and so on in allowing more patient face-to-face time.
So
Because they're all private practices, and you haven't got that authority to tell them how to run their businesses.
So you're exactly right. We don't have the authority to tell them how to run their business. Probably nor would we want to, because they know far better how to run their practices in their local community than I ever would. But we will have new measures in place as a result of this process, as a result of the national programme, as a result of the deployment of digital telephony, for example, that will allow us to understand the amount of activity that's being carried out. That will be monitored through the work. So it's detailed in that dull but important bit I described to work groups that will have a set of measures that they will be met, that each of the PCNs will be monitored against in terms of delivery of the things that you've described.
Thank you. Kate.
Thank you, Kev. Thanks, Gareth, for the presentation. I was interested in the care navigator role because, as I understand it, that could go hand in hand with the improvement in the digital technologies. And I was just wondering whether you could tell me who is a typical care navigator in Shropshire, for example. Is it a clinician, or because as I understand it, where it works really well is where there's quite an experienced clinician triaging the calls that then need attention and can't be dealt with digitally, and that could have some real benefits in terms of time saving rather than maybe going to the receptionist asking, etc., etc. So I was interested to hear a bit more about how that's working out.
I'll probably need to get some case studies for you, Kate, because I know the theory, but I don't know actually how it's been landed in individual practices. But again, if we go back to my live today's case study, I'm pretty sure that it wasn't a GP messaging me about the issue that I was dealing with. May well have been, but I doubt it. It will more likely have been one of the care navigators that had been deployed, and as you say, a clinician that will be guiding the individual to the right place. So mine have actually ended up in a pharmacy, but because it's a trained professional that can make that judgment, they know they're making that judgment with confidence. We couldn't possibly ask a receptionist that is not clinically trained to be doing that, to be carrying out that role. But perhaps I could get 1 or 2 case studies of where that's working particularly well for you, and send that across as a post-meeting note.
Yeah, thanks. Yeah, be interested in that, because I understand it as well that almost I think part of the risk of this, than the digital side of things, aside from the points that people have already raised, is that if you just kind of keep adding things, so if you still have the regular receptionist answering calls, and then you have a slightly different way of referring, that it's not necessarily as successful as if you just go and do and have quite an uncomfortable 6 weeks of the whole new system. But then everybody gets used to it, and I understand there's dramatic reduction in time, then freeing up time for the patients who want to come through in more traditional ways. But I was just wondering whether you've got to that stage yet.
So it's different across each practice, because they would be implementing it in different ways. So Riverside, for example, you can't now do a phone call without having gone through that process first, and that's worked quite successfly for them, but not always for the patient. So, and then they'll learn as they go along. There's a practice outside of this area which has a significant list size, where they potentially had better access arrangements in place by going to a digital telephony service. But because the expectation levels become higher, people's expectations have therefore not been met at occasion. It becomes even more difficult. So each practice needs to be tackling it in its own way based on their own patient needs as well.
Yeah, thank you. And just for our own question, as I understand it, it can go that can happen as an initial uncomfortable bulge.
Yeah.
But it then does settle down after a few weeks. But it sounds like a good idea where possible, just to go all in and have an uncomfortable few weeks. But I understand there's a whole range of ways people want to do things.
It's really difficult. It's about human behaviour, because quite often people will sit here and go, well, if Virgin can do it with holidays, why can't you do it with healthcare? Well, the consequence of Virgin doing it with holidays, and 10% of their patients, 10% of their customers say, I don't want to engage with that, they'll go somewhere else. And Virgin will just deal with the consequence of that and feel that that's in their best interest because they've got a better route. But our patients have got nowhere else to go. So we need to make sure that when we do something like that, we do that with a safety net that 10% or 5% or whatever the number is still has a route to access and care. We can't afford to lose them. So we have to go very tentatively on a practice by practice basis.
Thank you. Thank you very much indeed for that. Heather.
Number of things that have popped out at me, as you'd expect. Digital telephony is interesting. I mean, one of the major complaints that I get from residents at the moment is they hang on the phone for 40 minutes and then get cut off. Will that be stopped?
That's the theory. So I'm reticent to give a hard yes, because there were 51 practices deploying it in its own way, deploying it each in their own way. But the theory around digital telephony is that they have the capacity to absorb all calls coming in, and for an answer to be provided in a suitable way. So either answer or callback mechanism or message deployment, which actually with the old analog systems couldn't actually get through. So there's the ability there for that to happen.
Right. That will be an improvement. I am sure that when it happens, I will get lots of complaints. But on the back of that, one of the complaints that I've had several times is, yes, people have been cut off after 40 minutes several times when they have quite an urgent question or issue to actually raise with the GP practice. And they can't get through. And that forces them then to go on to A&E.
Yeah.
So will there be an urgent route on these things so that actually if something really is urgent, like a child, for instance, having a particular reaction, which is the last one I've got, that they needed to prove to the GP, needed to show exactly what happened, couldn't get through to do that?
So it's really difficult in that spectrum of what constitutes urgent and non-urgent. Our GPs are there to provide urgent and emergency care in the same way, well, urgent care in the same way as other aspects of the healthcare provision is. But I would always say, in any interaction with GP, if it's, I'm very conscious I'm talking about an individual example, but if it was to do with child health and there's a genuine urgent need, then actually 111 or A&E is entirely appropriate. GPs aren't always there within the next 30 to 60 minutes. Their timelines are slightly different.
This one was to try, this child was having particular reactions at certain times.
Yeah.
And the GP hadn't seen that, so couldn't quite understand it. So actually when that reaction happened, you need to be able to show the GP. My reaction to that was take the child into the surgery and say, because taking the child to A&E is not going to deal with the issue with the GP. So that was just the urgent route for somebody who can't get their medicine, that they've been given a hospital prescription and told to take it to the GP, can't get through to get it. I mean, actually, on that occasion, somebody went and stood on the doorstep of the flipping practice manager.
Yeah.
Said, I can't get through to get. You know, so there are a number of things that actually, if there was some form of urgent route, whether it's prescriptions or whatever, it might help things. Just a thought. But you can't deal with everything. I'm just raising those because they're the things that come to me.
So, but this should help with that because it should give it's called a disposition. There's an output from every call point that will give a disposition. Now, it may well be that if you can't get through, the messages may be picked up later and they may have missed that opportunity. But that would be the same as in 1975 with the GP that lived in somebody's front room that you couldn't get because they had a long queue of people outside. So I don't need to belittle that example, but
on the other hand, in a long queue, they would normally have let the child go to the front. So can I just carry on with, I've got a few more briefly. Have you got a mapping system of mobile phone signal and so on? Because most people who need access to this, I mean, in the very rural areas, it's a very rural issue that actually, even if you've got a smartphone and your Wi-Fi's gone down and you've got no mobile phone signal, you are finished. I'm also really concerned that each practice has a proper training slot for those people who need it, because if they don't have a proper training slot with those people, they're never going to engage. They need to have somebody there at some point who's going to go through the little old lady who's got a smartphone because it's their family have given them one. They know how to ring somebody, but they won't necessarily know how to download the app or how to use that. Just somebody to give them that reassurance. And I think that, and I have raised this before, I think that's a big issue, actually, because then you will get more people using it. Secondly, thirdly, the one I raise every time, community pharmacies. Just rural proof that one.
Yeah.
And a lot of this is to help get a better service in primary care, but actually help reduce going to A&E, because you don't want lots of people going to A&E. So what are we doing about working with this across the border into Wales? Because again, they may have systems and so on, but you will have people living either side of the border who son and daughter have the experience of a Shropshire GP and expect whatever happens there to happen actually in their parents' Welsh GP or vice versa. So there's a bit of cross-border work on all of this. One, to make sure that people understand that it's different, but secondly, that actually we need to be able to reduce those A&E visits through this whole system.
Yeah. So there's a number of questions in there, but just make a couple of reflections. So the first on the patient training, then absolutely every practice will be wanting to work with their patients in the best way they can to maximise the alternative routes. But fundamentally, the existing access routes will still remain where it's in their patient's best interest. In terms of the Welsh border, my name's Gareth, that was my heritage, but NHS Wales and NHS England are very different countries.
No.
And it creates a number of barriers across healthcare provision for all. And then NHS Wales, as far as I'm aware, doesn't have a similar programme of work. They will have primary care improvement in their own way, but it doesn't have the systematic approach that we're deploying within England and within Shropshire, Telford and Wrekin. And therefore, in many ways, we will need to live with the interactions we have with them. But that's probably a good point for me just to come back to one of the really key points that sits within the report. We have good primary care practice within Shropshire. It's all of the points that you raise are really important. But we have 51 practices, and generally, I've worked in a number of systems. In my kind of career background, being privileged to work in a number of systems, I don't think I've worked in any system where the significantly vast majority, if not for all, of GP practices are in the same place of trying to do the best that they can for their patients here. And that's not, it sounds odd, but it's not always the case. And every practice that I've engaged with, every PCN has this right at the heart of what they're trying to do, because they do hear the feedback around access. They're living with genuine resource constraints. When you look at the data in front of us, Shropshire, can't say this for Telford and Wrekin, but Shropshire is above the national average or regional average in most indicators. Now, we all want to aspire for outstanding healthcare, and I think we do in large part provide outstanding healthcare. There are things we can improve on. But I do just want to come back to the key message, which is provision of primary care services within Shropshire is actually something we can be rightly proud of within our healthcare setup.
And just to add to that, though, if you look at the Health Watch Shropshire report on primary care and GP access to GPs, there are some significant areas where improvement is needed, and it would be very useful once this has been implemented.
To monitor it.
Yeah,
to monitor it.
Yeah, to monitor it. Thank you very much indeed. Thank you for this question. Tracy.
Thank you. Oh, what did you usually? I actually work in the GP practice, which is, so we've got a lot of experience with this, and I think it's Station Drive.
Microphone.
Sorry, Station Drive in Ludlow, and I think they are really working well in a good GP practice, and you'll be aware of that. The system you talk about is great. We do, releasing up all these appointments, but actually, I don't think what's been taken into consideration is Station Drive. I'll talk about it because that's a fact I know. Is now over 9,000 patients. There isn't, even if you release all the appointments in the world for the GPs, there isn't the capacity. And we run with 4 ANPs that take all the duty doctor calls. So they triage with the GPs. From a personal experience, you release those appointments, but the backlog is so great that they're taken in an instant. And from a nursing perspective, the nursing team, we haven't got appointments for possibly for dressings 4 to 6 weeks. We don't have that capacity. So it all sounds really good, but I don't think we are addressing the actual capacity need for our GP practices growing. We've got more patients coming in, but we haven't got more GPs.
Yeah.
And an AMP is brilliant, but they often have to triage with that GP. So you take that, you free up that GP appointment. So you put the duty doctor calls onto an AMP, that's probably who spoke to you today.
Yeah.
But then they have to go back to that GP. They're not a replacement for a GP. And I just wonder, is that actually, and I'm aware that there's a shortage of GPs nationally, is that actually being taken into consideration? And just one other thing before we get, and I was looking at your building capacity, and I totally understand that you're talking about perhaps your diagnostic centre, we can refer patients for scans and things, and from Ludlow that won't work because of no transport at all. But our biggest issue, and this is my biggest issue, we have all this capacity for diagnostics, but we don't get the results from MRIs for 6 weeks, 8 weeks, 3 months. I spend a lot of my time writing to the medical secretary, chasing up results. Results are incredibly slow coming back for basics. Even a basic chest x-ray can be weeks coming back. And I think that really needs to be looked into. I mean, recently I've had an MRI, it's 3 months waiting for the patient to get that result, to come back to us as a GP practice. And that's holding up the system massively. So it's wonderful sort of increasing GP direct access to diagnostics, but if you ain't going to get the results back and you're waiting so long, you've got to chase them up. That's a failure in the system.
I completely agree. So a couple of things in there. So you'll see me furiously scribbling. So if you'd spoken to me about those timelines 6 months ago, I'd have nodded sagely and gone, we've got lots of work in this space going on. here and now, the improvement within diagnostics that Sathi obviously provide and Shropshire provide the diagnostic support is significantly improved, and I think we're one of the most improved systems in the country in terms of diagnostic access. So I'm really surprised to hear that. So I'll take that away.
It's not the access; it's just
the reporting. Yeah,
we're getting them really quick. MRI a week, urgent, but it's getting the results back. And
when I talk about access to diagnostics, I mean because it's two-part. So let me take that away and double check, and I'll pick up with a colleague of mine called Maureen on that one. On the workforce side, you're absolutely right, and sorry, in the developmental sessions, I know a couple of colleagues have been on. I've been really quite blunt up front to say that this won't deal with the capacity issues. What this will, the fundamental capacity issues, what this will do is make sure the capacity that we have got is used most effectively. But we do have a workforce problem within the NHS and within Shropshire. We sat around this table previously and discussed the Cabell Hub as one of the potential options in terms of trying to recruit GPs in. But I'll be really honest, I'm not sure that my son's some way from being a budding GP yet, but I'm not sure that the new generation of training individuals going through training are going to find general practice attractive because of the changing nature of society, the risk that they need to take in terms of the financial aspects of owning and running a business, as well as providing care. So we have a fundamental issue with GP recruitment and retention. We're doing all that we can within the system to do that, and there are a number of things that we are doing. And again, Shropshire does have its attractions to bringing GPs in, but we can only be so successful, and that's why we're trying to expand using these additional roles. They are not GPs. They are really valid and valuable members of the team, but they are not GPs. So we are trying to build these roles as much as we can. Now, I know you provided a couple of examples of where the AMPs don't necessarily make a difference. So I actually have quite a different view, because in many ways, yes, some of the patients will need to be tested with the GPs, but where they can be diverted to a pharmacist or a first contact practitioner or through to diagnostics without needing to go through a GP, then that does provide.
It's not criticism or brilliant, absolutely brilliant, but they're not a replacement.
They're not. But we can only use the resources we have available. So we'll try and maximise GPs, and then we'll supplement that elsewhere. And we have been relatively successful in that.
Good, thank you. Thank you.
Right,
Two more questions. Bernie, and then we've got Kate, and I think we need to wind this.
Thank you, Chair. Just very briefly, Gareth, it's page 5 of your document that reports 21 out of 51 practices participating, but that's not why I asked these questions. Mine are partly related to things that have cropped up. The results is very surprising, because that is one part of the system that can be fully automated, and not just to the requester, because the requester may not be in primary care, but also to the GP, to make sure that the GP automatically has the results, as well as the requester of any investigation. And this apparently doesn't happen, which is strange in a world when we're trying to automate and trying to improve IT. The second is with regard to the NHS 111 scheme, because numerous studies have shown very clearly that if you increase the number of experienced, senior, professional clinicians that answer the calls directly on the 111 system, then the number of people coming to A&E departments, to accident and emergency departments, significantly reduces. And I've not seen any data that have shown the amount of engagement in this area and in increasing the NHS 111 capacity with senior, experienced clinicians. And all of those words are important. And finally, I just wonder if we can have details of those 13 metrics around access to primary care and performance that you quoted in part of your response. And of course, if the NHS Emeritus scheme had been enthusiastically grasped, you might have more GPs now than you have. Thank you.
But it wasn't, though, was it? So you can't really say that.
But it still can. It's still live.
Do you want to answer those questions?
Yep. So on the 111, so interestingly, 111.
Can you just put?
Apologies, sorry, thank you for reminding me. So 111 has recently been through a re-procurement process. So it was initially provided by West Midlands Ambulance Service. About 12 months ago, they gave notice that they didn't want to continue to provide that service. They wanted to focus on the 999 aspect. So that was re-procured in September last year. And as part of that, the specification was redesigned with one of the focuses, Kendrick, to increase the number of senior clinicians helping do the navigation.
So who is that?
It's the initials of DHE. I forget what they stand for, but I can confirm separately. Went through a robust procurement process guided through by NHSE, I think Black Country, who are the commissioners for the regional wide 111 service. On the, I've lost track of my notes. So results, yeah, I'll pick those up. I've already said that I'm surprised by that, so I'll go away and find out what the issue is with the results, because that is surprising and disappointing. And then the third point, Bernie, I forget.
The metrics around access and performance.
Metrics, yep. So the quality and performance report is being reshaped as a result of these. I'm really happy to submit that separately for you to see. No problem at all.
Thank you very much.
Good. Thank you very much indeed, Kate.
Thank you, Chair. Two questions. One is the 90% of the population using NHS app by March?
Yeah.
April
Yeah.
24. Over ambitious? And is there anything we can do to support getting the message out? And then the other thing that I wanted to ask about, you made reference to self-referral. And could you just say a little bit more about how that's going? Is it successful? Has it been met? Have appropriate referrals gone through? Is it popular? Is it not?
So on the NHS app, I actually think with the thank you. I need a big sign saying press red button. I think I will need to confirm, because I'm sure this is a recorded message. I think we're actually the system with the most successful take-up of NHS app use in the country. I'll need to check that. And I think we are either there or thereabouts in terms of delivering the 90%. So I think we're in a good place on that. I'll get the actual numbers and share those. In terms of whether there's anything you can do, let me have a chat with my colleague Nicola Williams, who's leading the programme, because I'm sure there is. Off the top of my head, I don't know what that would be or what that would look like, but I think our engagement comms team would be really delighted to take your help on that.
Yeah, I mean, Shropshire Council and all of us as individual councillors have quite a good social media reach, and you know, I'm sure we would be happy to.
If I tell you so yeah, I'll take you up on that. But I'll make sure that our company are picking up on that. It's really good idea.
And the self-referral?
The self-referral, to be honest, Kate, I don't know enough about it, and I would be bluffing you if I gave you an answer. So please let me take that away and come back to you.
Oh, thank you. That's a shame, because I wanted to find out if you can refer yourself to different hospitals or to a hospital rather than just a different GP.
So the issue on the self-referral is the access route to direct pathways. And I think there are 7 pathways that you're able to now self-refer. I don't know what they are, and I don't know how successful we are, which is why I'd like to go away and confirm. That's not necessarily around hospital referrals. So the hospital referral process continues to be through GPs, because we need to make sure that the referrals that are going to secondary care only need to go to secondary care. They can't be dealt with by primary care first.
Because I wanted clarification, because I'm sure I've read somewhere some statement which said that primary care should not be the gatekeeper of secondary care.
Shouldn't be the gatekeeper.
So what does that mean?
Yeah. So it shouldn't be the gatekeeper in terms of holding the keys for access, but we do need to make sure that only appropriate patients go through. So there's a couple of good examples to bring that to life a little bit. So fit testing, for example, is a test that can be done which will identify whether you do need to go and see a secondary care consultant for a cancer pathway. If that can be done without the GP being involved, in, you can go straight to secondary care, but you don't then feel the hospitals can be confident that patients waiting to see their consultants are patients that only need to see them. So that can give you an alternative pathway to access secondary care, but we can have confidence that we're not using really valuable resource in secondary care. So it's about changing the GP from being a gatekeeper to a navigator. So if you present to the GP, you don't necessarily need to see a GP for that potential care, but they'll navigate you to a fit test. fit testing takes you through to the hospital, and that accelerates the way in which you can gain access to care without using vital GP time.
Thank you. So the answer to Kate's question, can you forward?
Yeah, I'll come back with those pathways and the success that we're having in those.
Good. Thank you. Thank you very much. I think we need to wind this up because you've been talking for 3/4 of an hour.
Apologies.
No, don't apologise. It's very interesting. That's why we want you to talk. Is there anything else you'd like to say to us before we move on to the next item on the agenda while you're here?
I think what would be good is probably 9 or 12 months down the line, rather than talking about what we will do, is come back and talk about what we have done. If that's okay, because this is a really exciting programme of work, but it's absolutely at the implementation stage rather than at the we have delivered stage. So I think that would be a useful time to come back.
Good, thank you. Okay, we'll put a date in the diary, and I think that's essential. We want to have this monitored. Now, you've got perceived as to monitor how well you're doing with this, and we'd like to also have that information as well to see if it is working, what isn't working, what we can do to make it work, because it's all our benefits that this works. And as been said, our major concern, I think, is access to the internet and access to people and training them and helping them to be able to use this system. Because I'm worried we're going to get a two-tier system. We're going to have those that can and those that can't. And those that can't are going to fall further and further behind. And I think we need to prop them up.
100% entirely part of this.
Yeah. Fine. Well, can I thank you very much indeed? I found that very interesting. So thank you very much indeed for the updates.
Thank you for your time.
Good. Thank you very much. Yes, please. Please.
Thank you very much.
Thank you very much indeed. We'll move on then. Item 7, update from Joint HOSC. Okay. Which is update from Joint HOSC Overview and Scrutiny Committee. The next scheduled session from Joint HOSC is the 27th of February. And the focus of the meeting is planned to be urgent and emergency care and an update on winter planning. Okay. Item 8, update from Health and Wellbeing Board. I don't know if we've got Celia here or not. No, Rachel, I believe Rachel's going to give us an update. Thank you very much.
Thank you, Chair. Yes, so Councillor Mott is unable to speak here, so she's asked me just to run through the last Health and Wellbeing Board. The meeting took place, I should check it before I start talking about that. So the meeting took place on the 18th of January. We had the meeting, as you know, is split into 2 parts. The first part is items for discussion. So there'll be a presentation. We have in detailed discussion, usually about half an hour discussion on those items, and we had 3 of those. And then the second part of the meeting will look at items that just are brought forward and by exception will be conversation, and then we have standard assurance papers. In the first part of the meeting, we discussed 3 areas in detail: social prescribing, the GSNA place update, and we discussed transport, including community transport. In terms of social prescribing, that was an update on the programme of social prescribing that now runs across all practices in Shropshire, focusing particularly on the adult programme, not so much on the children's. We're going to bring that back to a future meeting. Within the paper, there was some outcomes, sort of description of the programme, the outcomes around that programme, and updates to the board. I think it's important for Scrutiny to note, and interesting in the conversations around primary care, and one of those key roles within primary care, that we do have social prescribers across our practices. It's an integrated programme that's delivered with our primary care. It's also delivered with our voluntary sector and Shropshire Council as an integrated programme. And those social prescribers, they will prioritise particular areas depending on the PCN within that area, their priorities. So it could be falls, it could be pain management, but also healthier lifestyles as well within those programmes. And there's some metrics in there that were shared in terms of some of those outcomes with the board. A future update on children's social prescribing was asked, an agreement that we would be writing and supporting to our health colleagues to make sure that that is deliberately funded beyond just primary care. There's obviously lots of opportunities to join up in terms of secondary care. The GSNA plan update came also to Health and Wellbeing Board, and there was discussion about the progress around the GSNAs, particularly the place plan areas. We've obviously got thematic and web-based GSNAs as well, but the place plan, as you will know, we're moving across the 18 place plan areas with a view that those should be complete by the autumn time.
a comprehensive programme, and some of the examples were given of some of the opportunities and work and actions that have come out of the GSNAs. So the GSNAs themselves collect information, qualitative, so soft intelligence, as well as some of that hard data about health and wellbeing needs in those areas. Then through that engagement process, action plans are developed, it's not just for Shropshire Council, it's for health services, it's for town and parish councils, the voluntary sector in those areas, and then looking at making sure we monitor those actions and they're taken forward. I said, I think we're just looking around the room, I know many of you will have been involved within those processes, and examples around the work that's resulted from some of the GSNA in terms of highly conversation that will be taking place in Whitchurch and others to look at to implement the actions coming out of the GSNA work were discussed at the board, and the hard work of the teams involved and the engagement across all parties recognised. The final discussion piece we went into in detail was an overview around transport in Shropshire. It was just to give us a sense as a board of the transport network, the work that's been taking place at this point in time. There was a discussion that we would need as a board to understand more around community transport, but also particularly understand some of the issues around road traffic accidents and the increases that we've seen in recent years, and make sure that is aligned to the work that the community safety board look at, to make sure we understand those reasons for changing patterns around road traffic accidents and any actions that need to be put in place. That a future report will come to the next Health and Wellbeing Board in April on that particular issue from both police, fire service and health colleagues. So they were the three main items for discussion. There was then also a health protection update. We did flag measles, particularly as part of that update, and as you would expect me to say that whilst overall in Shropshire we have got high rates of vaccination around MMR particularly, we would want to encourage a continued uptake, and for anyone who hasn't had the vaccine to speak to their GP, but anyone who has symptoms, ring 111. Please don't just visit your practices. So there is work going on around measles, and just to bring that to everyone's attention, that came to the Health and Wellbeing Board. We also had a report, a thorough document on our substance use strategy and our action plan. That was brought to the board, and there'll be more detailed discussions on particular actions that will come through to future meetings. And again, I'll make sure that's circulated, because there might be items once it's gone back to the Health and Wellbeing Board that members would want to be interested in. It's quite a lot happening in the kind of drug and alcohol arena. Then I took my annual report, which I think I mentioned at the previous house, and I've circulated that to members on rural health, and we took that, shared that with the board, and obviously there's some recommendations in that which we'll want to be following up with, and I would hope that those recommendations align to the that was done through the Health and Scrutiny Committee. And then the final piece was that our prevention framework was endorsed, signed off, and there will be then an action plan that will follow as a result of that piece of work. They were the kind of key items that were discussed at the Health and Wellbeing Board. The next meeting is in April, and you'll see that there's some follow-on in terms of some of those items that will need to come back, particularly children's social prescribing. We'll be coming back to a future meeting. We'll continue to update on the GSNAs and the transport issues as well.
Good, thank you for that report. For the meeting that's coming in April, are we able to advise you of what would like to be discussed, or can we feed into your agenda or not?
Absolutely. So just that's a really good point. So what we have restarted, we had a meeting just before Christmas, was the coordination group that brings Health Watch, HOSC chairs and Health and Wellbeing Board chairs together to look at all of the kind of work programmes to make sure that we're aligning those. So Sophie and myself are picking up a conversation it was very difficult to do it over Teams. So we're going to get together and just try and map your current work programme, the Health and Wellbeing Board's current and future work programme, to align those, and Health Watch, anything that we should be including. We had our first meeting. We're going to do a bit of mapping before we meet again, and then so hopefully through that process we'll be able to make sure that we align what's being discussed at Health and Wellbeing Board and any deep dives that you want to do here as a scrutiny committee. So it was recognised that was a really important piece of work. The other element of that is obviously our co-chair of the Health and Wellbeing Board is Simon Whitehouse. There was a recognition that we need to align the work of the ICP and ICB as well into that, and some of that system-wide work.
Good, thank you. That's important, and I think that's a good step. Can I just? I've got Bernie first, and then thank you.
Thank you, Mr. Chairman. My first question is with regard to the and JNSA and the meal area, because this is contains an isolated area that has got very substantial needs, and I've raised the issue on a number of occasions previously, but we don't seem to have a plan for that particular area. And I would be very grateful if that could happen at the earliest convenience of the integrated care system.
So you mean a separate GSNA?
Well, there was an engagement process during which the issues of a particular part of meal was identified and agreed to need higher levels of intervention, because this area has the lowest 20% of adult population well-being and the lowest 10% of children's well-being identified, but we don't have a plan for that particular area.
So my understanding is that we've agreed that there'll be 18 place plan JSNAs, but where we need to do that, there'll be breakdown of particular actions and data within each of those areas. So where the Shrewsbury area is a particularly large area, so within that there will be subsets and there'll be specific actions that may relate to the meal area, but we wouldn't have a separate JSNA for meal, but it would be included within that large document identifying where you would want specific actions that might relate to a specific part of Shrewsbury.
But there is a coordinator for the north of Shrewsbury, but nothing for the south of Shrewsbury, which includes the meal area. So the north of Shrewsbury has had intervention, but meal hasn't.
I think are you referring to the integration work?
Yes.
So that's probably, so the JSNA is a broad piece of work that's to understand the health and wellbeing needs in particular actions. In terms of rolling out the integration programme, that if in terms of the pilot, that will be prioritised. I know there's certain areas, as you said, there's been interventions in the north. My understanding is that obviously we've got particular capacity, but that meal was looking to be brought forward later in this year.
But the need is now, and clearly that particular area is falling behind as a result of delay.
So I guess we are taking a holistic view of looking at all the needs across the whole of Shrewsbury and Shropshire. We have identified, as you said, we've got a phased rollout and we need to cover the whole of the county broadly and then put a targeted resource where we have it into smaller areas. So I think my understanding from that conversation is that so we started in the Oswestry area, we're moving across the county, and then we are looking at meal from within the resources that are available from April. And obviously we're happy to use the resources that we've got available, but recognise that there is a need and we'll join up where we can. It's not just about that particular coordinator. So I'm happy to take that away from the meeting, but we are trying to have that kind of overview through the GSNA process and balance resources with the need that we've got. But my understanding is there should be something in place later into this year.
But I've had no information about what is offered. But I have a general question as well, and that is what importance are you going to give to dental services in the plans for 2023, 24-25?
So obviously dental services as have passed the responsibility of the integrated care system. We know that it's a priority within Shropshire, and the Health and Wellbeing Board, for example, have seen a first report around dental access, which we know is an issue. It's for us as a kind of Health and Wellbeing Board and Scrutiny to make sure that we work or lobby the ICS in that regard, because it's the ICS and NHS England that lead dental access. There is a role for us to make sure that we monitor that, but we don't deliver the services. So you're right in terms of the integrated care strategy and integrated care plans. We need to make sure that we pick up dental access as one of the issues that we need to monitor and flag. It's a particular issue across Shropshire, Telford and Wrekin, well across the country as well. So we have, as a Health and Wellbeing Board, started to look at that. But I think you're right, we've asked for that to come back as a further update, and there may be further issues that HOSC then want to pick up particularly.
Do a separate.
But it sits with the integrated care system having our responsibility for dental care.
Thank you.
Yeah, good. Councillor Towers.
Thank you, Chair. Just two comments really on what Rachel's been saying. The first one is social prescribing. And just to say that we've been battling on this one in the WEM area for 10 years more now, since we first heard its sort of possibilities. And I have to say, Louise Walcroft is making a massive impact on it for us. And she's got I happen to be chair of the Oswestry and Lifestyle Centre, and we have engaged very positively with the local practice on that one, and seeing quite a good move forward, and starting to take up now, only in January, but I think we're about 10, 15 now taking up, and with Lewis's help, deputy manager, she's actually putting on a day to try and broaden use of social prescribing in the area too. So just to encourage people that aspect of the work is vastly encouraging in our part of the world anyway. And the second one was, I don't know much about being new on this committee, the Health and Wellbeing Board. Do we, as a committee, get sight of those minutes at all, or is it just coming through you? Because I think some of the points you've made, I want to go away and think about, but I don't know the detail on it. So I'm just hearing headlines all the time. And I'd like to dig a bit deeper into it. That's all.
I mean, so obviously they're public notes, so we can certainly, I think we did try and make sure that you got a copy of them when they went out, but I can link them with Sulphur to make sure that when they get published, you get first sight of those. As I said, we put in place this meeting to try and coordinate to make sure that we're not duplicating or overlapping, but we're getting that kind of right level of scrutiny and kind of oversight and partnership working. So I think that will support that aligning of agendas, and it will fit nicely with your work programming as you go forward. So absolutely, I think, and part of having this on the agenda, actually, this item was to try and make sure we were aligning it, because the Health and Wellbeing Board has a particular remit around ensuring that level of partnership work, and we had some really positive feedback in particularly the engagement around the voluntary sector and all partners being equal around there. But the hospital you will want to make sure that you're scrutinising those areas that need to be that you want to have a deeper dive on. So this is part of us, and we can keep refining that through the work programme process to make.
Yes, I don't like to comment too much unless I know the detail and read stuff in the first place. So that would help me. Thank you.
Thank you very much indeed. Heather.
Thank you. A couple of things. Social prescribing we get to hear about. A lot of the public don't, and I'm not sure that actually the communications around that, and I don't know whether the Health and Wellbeing Board may look at that, because actually it's a very valuable part of what health services deliver across the board, both mentally and physically in many respects. So just looking at that communications strategy will be important. Furthermore, I'm not sure whether you work cross-border on that, because half of my division won't have access to it, but actually we now have a cross-border agreement. So it may be something that maybe ought to be thought about, so that you don't have to change your doctors to get your social prescribing. And secondly, just looking at the vaccination, and one of those things that have been cited about vaccination for MMR, and all vaccinations, is that actually it's difficult for parents, because it's usually during the working day and they have to take time off to actually take their children to the GPs to do that. So it's actually not easy. I can remember when I was at school, it was done at school. Many things were done at school, and therefore it was done in the working day. And if parents could be there, they could take time off. If they couldn't, they'd give them permission. So there were a number of things around that. And again, there's a cross-border issue with this, with a third of children in February in primary school, for instance, coming across border. And if you don't have a similar vaccination programme going on in the next village or two or three, then you're not going to begin to reduce the numbers of people getting measles. And having had measles as a child, and quite badly, it's not a pleasant thing. Nobody needs to get that. Furthermore, I have a daughter who could never have the MMR when she was young. The other three did, because it was grown on egg at that point. So it's about protecting those who can't take the vaccination as well as those others. So there's a whole bit here, because the border is porous. It doesn't really exist in anybody's mind. So there we go.
That's a good point. Do you want to comment on that too?
This is a few things. I mean, I think in terms of the social prescribing, absolutely, we do need more service. The Healthy Lives team who lead that service. It's a fantastic service in the fact that it's, as I said, jointly funded. So the majority of the money comes through NHS England, to your, which is to your point, through to general practice, who then that then comes through to our Healthy Lives team, who fund the link workers. We then fund the voluntary sector, who do a lot of the community directory and development, which I think there is a strong link there with Wales, and you can still signpost people into other services. And then the final bit is there's obviously the oversight and the management of the Shropshire Council and the health check element as well, because they're inevitably all linked. But I think there is an issue around it being funded through England, and how do we link in, because there is a difference because of the funding streams, unfortunately. So there is something about how we can break that down potentially. Yeah, and
I think the important thing is that the Welsh Government, as far as I can tell, have quite an emphasis on prevention, and actually this fits into that.
And there's a bit for me which I'll pick up with Gareth as well, around care navigators and the various roles in primary care, because again that can sometimes become confused, but there's a real opportunity there. I think the vaccinations, you will know, absolutely agree, we need as many people vaccinated as possible. That's, you know, the herd immunity, if we get to 95%, will prevent those who aren't vaccinated, can't be vaccinated. It will help protect the population, which is why the 95% is so critical, because it's such an infectious disease. We have, whilst the majority of the work is call and recall to your practices, and obviously they are being as flexible as they can around appointments, but we have had the conversation on that this morning. We are looking at where you need to do targeted work to make sure that we do reach, because there is a variation across practices from 100% of people being vaccinated, or young people particularly, to about 80% in Shropshire, and that's the bit we need to focus. We are doing focused work and outreach in those areas, but it is around accessibility, and I take your point. That is something that the team are monitoring with primary care to see where those areas where you've got lower uptake, can we do some look differently, a bit like we did in the vaccination programme. So absolutely take point, but the strong message is, if you haven't had the vaccination, adult or child, if you get in touch with the practice, and we can is the key at this time.
Good. Thank you very much indeed for that, and for answering those questions so very well. Any more on health and wellbeing, we'll move on. Okay. Thank you. Item 9 on the agenda, update on the rural proofing and health and care report. I'll read something, and I'm sure Heather would like to then comment. Heather and myself presented the report to the Cabinet on the 17th of January, and I'm pleased to say it went very well, was very well received, and Cabinet are now preparing a response to this committee, which will include an action plan of how and when the recommendations will be implemented. We also presented the report to the People Overview and Scrutiny Committee on the 24th of January, and they also adopted who adopted recommendation 7 of the report, which will see the People Overview Scrutiny Committee also using the rural proofing for health and care toolkit as part of their scrutiny process. Tanya Miles, Executive Director for People, also invited Heather and ourselves to present the report to SHIP. The report has also been shared with Joint HOSC on the 27th of February, and the ICB date, at a future date. So that it went down very well. I think we've got a lot of people on board. There's a lot more to do. We're trying to stress to people that although we've done the report and presented it, it's not the end of the day. It's not the end of the situation. It's only an opening, so we can proceed and get more and more people to read the report and adopt it. Heather, I'm sure you'd like to say something, because you wrote this report.
Thank you. Well, Sophie wrote it very, very well, but yes, we worked on it it's a good report. I think the most important thing is that those areas for future work that were coming out of that we mustn't forget, that we do need to carry on with those, because that they were around access, and we couldn't do all of that in the report, and that's something that's coming up in all sorts, including the JSMEs and so on. So there are bigger areas, but I'm really pleased, and I'm really pleased that that we've done a piece of work that no other council has done so far using the rural proofing toolkit, because it's nice for Shropshire to be doing something that's a bit different. But the next stage, which Jeff and I are very keen to do, is to make sure we roll it out much further to all rural areas, because it then begins to be embedded in everybody's thoughts.
Yeah.
And it's the embedding in people's thoughts that's the most important thing, certainly for Shropshire, certainly for along the marches in the partnership, but actually eventually unless it's embedded further afield, it won't get embedded in government.
Good point. And one thing we did stress, they were going to talk to our partners over the border, as we said, to see if we can get that adopted, which is great. If everybody's working off the same hymn sheet, then it's great.
Just a quick question, Heather, third chair. The LGA was mentioned at one point. Are we, obviously we have to go through our own processes within council here. You talked about rolling it out to other authorities and cross-border, but the LGA I thought was a very exciting route for us to have. And how's that going and what's happening there? How far we got?
I haven't addressed that yet because I was waiting for everybody to adopt it, because if everybody here, and there was a bit through from the ICB or the ICP where they were beginning to look at that as well, which is really important. But once we've all adopted and think it's good, they wanted to see the draft anyway, but I've stopped from doing that until we've finally adopted. And I think once Joint Hosc has done that, then I will send it to Mark Norris, who was the senior policy officer who wanted to see that.
Yeah, because we'll then be able to say how well it's gone down, and then undoubtedly be able to sway them to look at it seriously more. I would hope.
It has to have an effect, I think, in cascading it out. It just has such unanimous support within the county in all levels. It's great.
Just going to add, I think, on the health side, that we'd agreed to take it to the next Health and Wellbeing Board. So that was just because it's place-based rather than taking it systematic, it's particularly about rural health. So we'd agreed, and then you're right, we did discuss, we had the Integrated Care Partnership meeting. That was last week, where the rural strategy that Health are developing was discussed, to which we sent them a barrage of information, including the report and task and finish group, to say there's a huge amount of work already being done in this area. Can we ensure we align? And so that's one of the reasons it's come to the Health and Wellbeing Board. The right partners will be around the table.
Great. So when it was discussed, how well did it go down? Did it go down very well?
So it wasn't discussed in detail. What was landed through the big conversation was that a rural strategy was being developed as an output, to which we said there's a huge amount of work that's already been done that needs to be taken account of in developing the rural strategy. And we said we'd have a discussion at the next Health and Wellbeing Board when we've got all the health partners around the room as well, so that they hopefully will adopt then the output.
And Shropcom are interesting, so I'm sure we'll be a discussion about that in post that may or may not exist.
Well, that's good. Thank you. So it seems as though we did a good report and it's gone down well, but it's still more to do, more people to adopt. Thank you very much indeed. Let's move on then. Item 10 on the agenda, work programme. Sophie's going to update us on this.
Thank you. So in terms of the work programme, within your reports agenda pack for this meeting, that should have been included in there, so I'm not going to share it on the screen unless needed. The first item, rural proofing, health and care, the work has already been outlined by both, so I'm not going to follow that up any further. Primary care development and needs topic has been worked through as agreed in the the November committee, and was agreed to be a whole committee working. So use of informal sessions working up into today's meeting with colleagues from the ICB, most notably Gareth, to develop the committee's understanding of the topic and inform the lines of inquiry and the questions from item 6 of today's meeting. The other areas of work is the local care programme and mental health, which, due to the fact that we're approaching the end of the council cycle, these will then form part of the prioritisation discussions for the committee's work programming. So anything that hasn't been completed as of yet will not be lost. It will move across to the work programming sessions for the committee to discuss and decide what should be done in which order. And indeed, if there's any new areas of topics or work which you feel needed to be included as well. These work programming sessions have been scheduled to take place in March, and you should have received invitations to those. They are open to all members, not just the committee, and the dates, times and venues have therefore been included in members' calendars. And these sessions are that opportunity for officers, portfolio holders and partners to share with members what's coming up over the next council cycle, sharing existing service and high-level project plans to identify what's happening and when and how. Then for the committee to identify, along with the previous work that's been shown, what you'd want the priorities to be going forward. That's where we are with the work programme. Thank you.
Thank you very much. Need any questions on that? Are we all happy with that? Good, thank you. You'll be pleased to hear then the next item is number 11, dated next meeting, which is 10 a.m. on Monday, the 11th of March. And as I believe that's it, actually, basically. So thank you very much indeed for coming today. I hope you found it interesting. And we'll see you on the 11th of March. Thank you. Bye-bye.